Upper limb surface anatomy. Forearm and cubital fossa. Epicondyles. Palpate the medial and the lateral epicondyles of the humerus. The lateral epicondyle is the common origin of the forearm extensus. The medial epicondyle is the common origin of the forearm superficial flexus. The ulnar nerve passes posteriorly to the bone and may be damaged here. Proximal, ulnar, and radius. Palpable structures. Palpate the olecranon of the ulna and the subcutaneous bursa overlying it. Head of the radius. The head of the radius is palpable about 1.5 centimeters distal to the lateral epicondyle. It is the smaller proximal end of the radius. Feel it roll under your 2 fingers by pronating and supinating the forearm. Distal, ulnar, and radius. Palpable structures. The distal end of the ulnar is smaller than the proximal end. Palpate the head and the styloid process of the ulnar and the sharp subcutaneous posterior border. Note the ulnar does not articulate with the carpal bones. Between the ulnar and the carpal bones is a triangular fibrocartilage of the wrist joint. The distal end of the radius is larger than the proximal end. With the thumb and index finger, palpate the tips of the radial and ulnar styloid processes, noting their levels. The radial styloid is always lower by about 1 centimeter, and this is important during surgical management of a callus fracture of the distal end of the radius. The distal radius articulates with the scaphoid and the lunate. Cubital fossa. The cubital fossa is a triangular area in front of and slightly distal to the elbow. An imaginary line bound the cubital fossa proximally between the medial and the lateral epicondyles of the humerus. The brachioradialis muscle forms the lateral border. To find the brachioradialis muscle margin, flex the semi-pronated forearm against resistance. The pronator teres muscle forms the medial border. The margin of the pronator teres muscle can be estimated by an oblique line extending between the medial epicondyle and the midpoint along the length of the lateral surface of the forearm. The apex is where the oblique line of pronator teres meets the margin of the brachioradialis muscle. The brachialis muscle forms the floor of the cubital fossa. Contents of the cubital fossa. The major contents of the cubital fossa from lateral to medial are as follows: biceps brachii tendon, brachial artery, median nerve. The biceps epineurosis to the ulna covers and protects the brachial artery and the median nerve. The brachial artery pulse in the cubital fossa is the position where a stethoscope is placed to hear the pulse of the vessel when taking a blood pressure reading. Superficially, the cephalic, the basilic, and the median cubital veins are visible in the subcutaneous fascia overlying the cubital fossa. The cubital fossa is often the site for peripheral venous catheterization. The ulnar nerve passes behind the medial epicondyle of the humerus and can be rolled here against the bone. A fracture of the medial epicondyle of the humerus can damage the ulnar nerve. The radial nerve travels in the forearm deep to the margin of the brachioradialis muscle, anterior to the elbow joint. A fracture or dislocation of the neck of the radius can damage the deep branch of the radial nerve. Movements of the elbow joint. The elbow joint is a hinge joint. Brachialis, biceps brachii, and the brachioradialis muscles perform flexion of the elbow joint. The triceps muscle performs extension of the elbow joint. Pronation occurs solely in the forearm. Pronator teres, pronator quadratus cause pronation of the forearm. Supination returns the hand back to its anatomical position. Biceps brachii and supinator cause supination of the forearm. The head of the radius rotates within the annular ligament. This occurs in pronation and supination, as you can demonstrate it on yourself. Throughout this movement, the ulna remains almost stationary, and it is the radius that moves with its head rotating and its distal end moving in an arc over the ulnar. Elbow injuries. Radial nerve injury. The radial nerve supplies all the extensors of the upper limb, including those of the wrist. Damage to it causes the forelimb to adopt a characteristic position with a flexed limp wrist, i.e., wrist drop. In this state, grip strength is lost, since for maximum power in the digital long flexes, the wrist has to be held in extension. Radial nerve damage may occur in the arm from a midshaft fracture of the humerus, causing wrist drop. Radial nerve damage may also occur at the elbow, for example, from a fracture or dislocation of the neck of the radius, or dislocation of the superior radioulnar joint, causing wrist drop and an inability to extend the fingers. Median nerve injury. The median nerve may be damaged in the cubital fossa from a supracondylar humeral fracture. It may also be damaged at the wrist from a carpal tunnel syndrome. Ulnar nerve injury. The ulna can be dislocated posteriorly. A fracture of the medial epicondyle of the humerus can damage the ulnar nerve. Because the median and the ulnar nerves both supply forearm muscles, there is no dramatic motor loss except for abduction and adduction of the fingers, though there may be some clumsiness. The ulnar nerve may be damaged at the wrist from a slashed wrist. In this case, the finger flexes supplied by the ulnar nerve are not affected, and so the ring and the little fingers will be more flexed than if the nerve is sectioned at the elbow. Paradoxically, the hand looks worse, although few muscles are inactivated. This is referred to as the ulnar paradox.